Any comments, Hugo?
Well, very interesting surgery. Always we learn a lot from Carl. He's an excellent surgeon. I've never seen a full contact lens in the vitreous cavity. So this is very interesting, and we always learn new things.
So it's very interesting that you have a clear lens, so you just go and do a vitrectomy, and it looks like that nail basically folded the contact lens, pushed it towards the ciliary body around the lens, and ended up in the vitreous cavity. And the key was to stain the lens to make sure that you don't leave any parts behind. Is that correct?
Yeah, that's the most important thing, yeah, because it breaks up, especially if you start eating it with a cutter, it breaks in small pieces, and they are transparent, obviously, and you don't retrieve them from the periphery, unless they are really very well colored.
And the key is to remove. And you know what, it was actually a case presented earlier on where you have and I think that was Virgilio Morales who presented a phakic IOL in a patient that slipped around the ciliary body. You know, when you are a high myope, the zonules are loose, and that lens just slipped behind, and now you have a 20/20 patient with everything is clear, and you have this large intraocular lens in the vitreous cavity. And there was also another case where it was presented where the DSEC flap, I think that was Kevin Blinder that presented that the DSEC flap was actually dislodged, the patient was aphakic, and that DSEC flap ended up in the vitreous cavity. And that becomes very challenging because the cornea is now hazy, so you don't have really a clear view. And that is one of those times where the endoscope becomes helpful for you to be able to remove. Do you want to comment?
And, these cases cause PVR as well. It was very hard to remove these flaps.
Exactly, and I think Carl himself had a case where I think you were doing a corneal transplant, and the transplant ended up in the vitreous cavity. And then you had to, do you want to comment on that one, Carl?
Yeah, I was an aphakic trauma patient and aneuritic aphakic patient, and we did the TKP, and then the graft actually, the suture of the graft broke, and the graft fell down in the cavity. And of course, it's an open sky situation, very difficult to retrieve or to visualize the edge of the transparent graft. And so we filled it up with viscoelastic to retrieve it and to suture the graft again.
Great, thank you.